I'd like to welcome you today to our symposium on neurotechnologies for human applications. And we have a great lineup of speakers today. And I think one thing you'll see is it really spans across novel applications of FDA-approved implantable devices, as well as investigational devices. Our speakers are Claudia Angeli, who will speak on closed-loop spinal cord stimulation. Philip Starr will tell us about in-home chronic human brain recording. Nanthia Suthana will speak on ambulatory human brain and behavior recording. Michelle Armentia-Salas will speak on visual prosthesis. And then we'll hear from Harrison Walker on directional leads. And then we'll wrap up with an important final talk from Winston Chiong on neuroethics. So with that, we'll turn it over to the first speaker.
So I will be talking about overground walking after motor complete spinal cord injury. This is a collaboration that has taken place over about a 9-year period. We know that the spinal cord and neural control of walking has the capacity to oscillate independent of supraspinal influence. That means that the spinal cord is smart enough to generate certain patterns without necessarily the influence from the brain. It also has the capacity to organize flexors and extensors for the lower extremities as it generates walking, the inner limb coordination, the interaction between specific sensory cues. And we know that motor output actually improves with specific practice. That means that whatever you practice, that's the pattern that actually is going to improve. When we actually put individuals with motor complete spinal cord injury or even motor incomplete spinal cord injury on a treadmill and we step them with manual assistance, we actually see that there's different motor patterns that are generated from very little activity from the muscles to quite a bit of activity and coordinated activity throughout the steps. We see that this actually goes from a low level of activity in some individuals and high level of activity in others. And this is due to what we call this resting level of excitability of the spinal cord. So from previous research, we know that the spinal cord, the spinal circuitry, plays a very important role in the generation of motor output, and it can interpret very complex information coming from the periphery, sensory information, the ground reaction forces, and the spinal cord is actually the primary controller for motor behavior. With this information, we set out to do initially a proof of principle study looking at implanting an electrode, a 16 electrode array over the lumbosacral spinal cord to see if we can improve these motor patterns that were generated as a result of activity-dependent practice. And we did two different comparisons of individuals that received locomotor training, with the first group receiving 80 sessions of stand training, followed by 80 sessions of locomotor training. And then we implanted a second group of individuals that actually did both standing and the locomotor training simultaneously. They just alternated days for that specific practice. So you can actually see that the two groups were fairly similar in terms of clinical characteristics. They were similar in age, they were similar in time since injury, and the level of injury. We had individuals that were motor and sensory complete, as well as motor complete but sensory incomplete, and both groups had two of each. So the only difference, again, was that one group did 80 sessions of standing first, and then they followed by 80 sessions of stepping, all with stimulation after the implantation. And then the other group, we actually interleaved the two training paradigms. When we look at the data, we actually compared how the two groups did in standing ability. And the first group, you can see that the top graph, the blue bar graph, shows the amount of knee independence that these individuals could have throughout a full training session. And the second group did better than the first group. So those that actually stood and did locomotor training together in alternating days did better in standing than the first group. And then the green bars are the amount of actually hip independence and knee independence. So that's all is standing fully independent. And we were not as successful with the first group, but certainly the second group showed that they could actually stand for almost the full training session with both hips and knee independently. So now we'll show a couple of videos. The first video will be one individual, the best individual out of the first group. So if we can play the we'll show the individual from group 2. So the big difference between those two individuals that you saw in the videos is that the first individual from group 1 had a thoracic level 4 injury, and the second individual was a cervical 5 injury. So he had very little trunk and hand control, but even so, he was able to maintain independent knees, and when holding on, he was able to also maintain independent hips through the standing when he was receiving stimulation. Now, for this, when we compare walking, we actually can see that intent plays a big role in individuals' ability to step. And if you look at the motor output from stepping, in the left-hand side, you see that the individual had the intent to step the right leg while he was receiving assistance on the left leg. And the motor output is actually appropriate for stepping that right leg. So there's coordination on the right leg muscles, but there isn't appropriate coordination on the left leg muscles. But when the intent changes of his intent is specific to the left leg, then the appropriateness of the coordination actually switches. So the spinal cord is able to modulate that and interpret that information coming from whatever supraspinal information is coming through, and able to organize the muscles appropriately for the intent of the individual. So if we can play the video for the left slide. Play the video for the right. Only difference between those two videos is the intent of the individual to focus its effort on the left leg or right leg independently. And the simulation was the same, nothing changed other than his intent. So this means that the spinal cord has that capacity to organize the different intent and information from the periphery. Now, where we actually were able to be able to get two individuals out of the second group was that they were actually able to walk over ground fairly independent. And one of the things that we found was that these two individuals reached the ability to stand and step with the same stimulation configurations with just very minimal changes. So there's either some changes in voltages or some changes in frequency that were needed for them to be able to stand for prolonged periods of time when they weren't necessarily walking or stepping. So one of the big things is that individuals need to manually make these changes right now, and if they're walking or just having to stop and wait for traffic to go by, their ability to stand with a stepping configuration is very fatiguing to them. So they need those parameters to be adjusted for them to be able to stand for prolonged periods of time. But both individuals actually they converge into one single configuration with some parameter changes. So if we play the video on the top. Okay, and we'll play the video on the bottom. So this is the same individual using the same simulation configuration, same pattern of stimulation with some minor differences in stimulation amplitude for both standing and stepping. So our objective for this Brain Initiative project is to use the information coming from the accelerometer inside the neurostimulator and use that to gather information to see if the individual is actually moving or standing still. So detect these changes in position, and through a predictive algorithm, be able to make changes to the stimulation to optimize for the task. So if the individual wants to walk, or if they want to take a break and stand for a defined period of time, the algorithm will automatically change those stimulation parameters. And the other aspect of this project is bladder. Bladder it's a big issue with individuals with spinal cord injury. They do not have the ability to manage, to have a good bladder management program, and to the integration of bladder control and really monitoring of blood pressure as we train individuals for storage as well as voiding, integrated into a closed loop algorithm to change stimulation parameters as well during the stimulation. So our goals is to pretty much develop technology that will interact with the currently available stimulators and facilitate the implementation and integration of training programs really for the recovery of locomotion and bladder function in individuals with acute spinal cord injury, to promote safe long-term use of the technology in the home and community. This is really a group effort between a number of investigators as well as all of our research participants that really put a lot of effort in the training coming in the lab every day. So, and the next presenter will be Phil Starr.
Okay, I'm going to be talking about in-home chronic human brain recording in the motor system. This is going to be in patients with Parkinson's disease who are already undergoing deep brain stimulation for their clinical problem of Parkinson's disease. So a lot has been learned in Parkinson's disease from invasive human brain recording, and most of this has been done either intraoperatively or perioperatively from externalized leads in a hospital setting. So we could learn quite a bit more if we could do the same invasive recordings over long periods of time with very high volumes of recordings in patients' homes during naturalistic activities, and that's what my talk is about. We used in this protocol a new neurotechnology device, Summit RC+S. It's an investigational deep brain stimulator and sensing device that has been available since 2018, but only for investigational purposes. It is from Medtronic, but the protocol was designed by us, and the devices were provided for free by Medtronic. So the first slide shows basically what we did. Here, we're going to talk about the first 4 patients in the study who were bilaterally implanted with the Summit RC+S device, and the figure shows the configuration. Patients had bilateral RC+S, each attached to a subthalamic nucleus deep brain stimulator electrode for the purpose of therapy, delivering therapy, and sensing, and the RC+S was attached to a motor cortex electrode just for the purpose of sensing. And these patients can then transmit wirelessly by a few feet up to a small communicator that can then transmit over a distance of about 40 feet to a small tablet computer that can be in their homes. We did intensive data streaming for many hours for the first month after device implantation, but prior to initiation of stimulation, so as to understand the brain physiology underlying the fluctuations from effectively medication off states and medication on states, which I'll be illustrating in a bit. We then did ongoing sensing at home after the initiation of standard deep brain stimulation therapy in order to understand the effects of DBS and to test and begin to implement adaptive or feedback-controlled deep brain stimulation. So this slide illustrates where the electrodes are. The upper left shows an axial MRI showing the 4 contact cortical leads on each side spanning the central sulcus, which is indicated with an arrow. So we have contacts over primary motor area as well as primary sensory area. The subthalamic nucleus, the white dots, are the CT artifact from CT MR fusion, showing the leads located in the subthalamic nucleus bilaterally. We also show here in the middle just examples of the local field potentials, 2 channels from each subthalamic nucleus and 2 channels from each motor cortical area. We did want to confirm that we could obtain so-called broadband gamma responses from this device with the motor cortex electrode. We expect that when movement is initiated, broadband activity up to 200 hertz or so should be detectable from primary motor cortex if the device can detect frequencies up that high. So here on the right of the slide, we've just done a simple motor task with these patients. This is right after implantation. The dotted line shows the time of initiation of a simple movement. So when movement occurs in this motor cortex ECOG recording, you can see the expected beta band desynchronization here in blue, and then this very broad band from 50 up to 200 hertz of activation, as has been shown with externalized ECOG leads recording from externalized devices. So now we can show the same physiology up to high frequencies using this completely implanted device. So I'm going to show a video which is really going to illustrate the kinds of brain behavior correlations that we can see with this device. This video is going to show a patient not at home but in the hospital one day after implantation. The remaining data I'll show after this will all be home data recordings. We picked this because we wanted to capture a dramatic transition in this patient from an immobile state where he's bradykinetic and rigid, and the state that he transitions to after taking his Parkinsonian medications, which is mobile but very dyskinetic. And this is the problem that these patients have for which we've implanted deep brain stimulation. So the video is about 30 seconds, and what you're going to see on the left is the video of the actual patient starting out immobile, and then after a few seconds, he will begin to show involuntary dyskinetic movements. Then on his right, there will be an upper trace of the motor cortex electrocorticography trace synchronized with the video, which will show after the transition to the dyskinetic state the appearance of about a 70 hertz oscillation in motor cortex in the spectrogram that coincides with the onset of dyskinesia. The lower trace is going to be the subthalamic nucleus local field potential, which at the beginning when he's immobile will show a very strong oscillation in the beta band, about 20 hertz. And that will suddenly decrease when he makes the transition on the video from the immobile state to the dyskinetic state. Okay, so all the rest of the slides are going to be data from these patients at home. And using this device is the first time that we've been able to record continuous or near continuous neural signals from multiple channels in the home environment for many hours. We don't have a neurologist at home in the room to tell what motor state this patient is in. So we have to have some way of telling if this patient is in one of those off states where they're immobile and rigid, or the on state where they're moving around but may have the complication of levodopa-induced dyskinesias. So to do this home monitoring, the patients used a wearable. This is the PKG watch from Global Kinetics. And this gives an output, as illustrated in the lower left of the slide, gives an output of a score for bradykinesia and a score for dyskinesia. And you can show that these occur essentially at opposite times when the patient is bradykinetic or slow, and they tend to be dyskinetic, that is, they're mobile but have excess involuntary movements. So we collected about 80 hours of home recordings in this patient in the time after implantation, before stimulator activation. And we plotted power spectra, as shown on the right, for 10-minute segments of data. This case is the average 10-minute segments for those data in one of these two conditions. The blue line shows all of the recordings over many hours when the watch said that the patient was immobile, and this shows a prominent peak in the power spectrum in the beta range. The scale didn't make it onto here, but this is about a 20 hertz oscillation. Then in all of the hours of recordings where the wearable showed that the patient was mobile, the power spectrum of the subthalamic nucleus field potential does this. It has a dropout of that 20 hertz beta oscillation. Below this is the cortical electrocorticography signal recorded at the same time on these 80 hours or so of recordings. And whenever the patient is mobile and dyskinetic, as shown in the green line, this about 80 hertz oscillation appears. And the beta band activity does decrease over motor cortex. So what this slide illustrates is it shows that what we observed on the previous video, that 30-second recording, can be recapitulated over many hours of recording as segregated by a wearable monitor, with patients taking their normal schedule of Parkinsonian medications. So one important question in the field of decoding motor state in Parkinson's, and this comes up in many other brain disorders, is how many brain sites do you need to be able to understand the relevant brain states for a particular disorder? So in our protocol, we deliberately implanted two different areas of the motor system, subthalamic nucleus and motor cortex, and we asked the question, these 4 patients, how good are we at decoding the effectively on versus off states, that is mobile versus immobile states in these 4 patients. On the left here just shows the total number of hours that we recorded in these patients. So over these 4 patients, we show the hours recorded during awake times and asleep times just in that first month before starting therapeutic stimulation. We collected over 1,100 hours of 8-channel recordings. Then we asked the question, if we want to, how accurate are we at decoding the patients as immobile or mobile based on receiver operator curve analysis, looking at the area under the curve. So if you just look at single site activity, such as the STN beta activity or motor cortex gamma activity, you can do pretty well, but you get around a 0.7 to 0.8 area under the curve over these different patients and different channels of recording. But if you actually combine both targets, and that's shown over here on the right of this graph, you get an area under the curve which is closer to about 0.9, so you get much better decoding of motor state when you do multi-site recording in the motor system. So what I talked about before is a form of so-called supervised learning. That is, we recorded many hours of data at home and then used a wearable monitor to separate those data by immobile versus mobile. That's labor intensive, of course, to analyze all the wearable recordings. Ideally, for this kind of technology, you would like to be able to segregate brain states in an unsupervised manner simply by using a mathematical algorithm to separate states and see if they correspond to a physiological state, and that doesn't involve nearly as much analysis. So here we did this using a clustering algorithm adapted from a paper in Science published in 2014. And what we show here are many superimposed power spectra of 10-minute segments of data. So each power spectrum is for a 10-minute segment of data from the 80 hours of recording. And then we allowed the clustering algorithm to work on these power spectrum and see what it decided were the different clusters. And in fact, this clustering algorithm did, for the subthalamic recordings, determine that there were really 2 clusters of power spectra, in purple here and in yellow. The purple one has a big peak in the beta range, about 20 hertz. The yellow does not. And these clearly correspond to those immobile versus mobile segments, as we did in the supervised learning in the prior work. Likewise, in the cortex, the unsupervised clustering algorithm clustered into 2 different clusters with this strong 80 hertz oscillation in one of those clusters, and that clearly corresponds to the mobile but dyskinetic state. We also asked what happens now with therapeutic deep brain stimulation. What does it do to these oscillatory markers of Parkinsonian state? We know that chronic therapeutic DBS is quite effective for improving patients' mobility and reducing bradykinesia and rigidity. What happens to this subthalamic beta activity, thought to be a biomarker of this Parkinsonian akinesia? So here we have violin plots for the beta activity from 2 different patients, one here on the left and one on the right. So in this patient, which is the first in the protocol, you can see this hourglass configuration of the distribution of beta activity corresponding to those hours when he was off and immobile with the higher beta, or on and more mobile, and that's the lower beta activity. Then we recorded about 40 hours of activity at home during DBS, again, with their normal medication schedule, patient moving around their home as needed, or sometimes going outside the home with the recording device. And the distribution of beta activity was collapsed from this bimodal distribution into this more physiological unimodal distributions in both cases. So in this technology, we can now start to study over long periods what are the effects of acute and chronic deep brain stimulation on these biomarkers of brain state. Finally, we've started to use our understanding of brain state from home recording to implement adaptive deep brain stimulation. That is, having the stimulation, instead of being constantly on, as in standard therapeutic stimulation, we want it to be smart and adjust the amplitude of stimulation according to changing brain needs. So after starting therapeutic stimulation, these patients are still requiring some of their levodopa medications, and they need more medication when the need more stimulation when the medication wears off, and less stimulation when the medication is effectively working. This shows the beta activity and stimulation current on the bottom in one of our patients over about 8 hours during about 3 medication cycles. Here with the blue, this is the input signal to the classifier, and the red lines are the 2 thresholds of beta activity at which stimulation changes are triggered. So here in the morning, he's actually taken his medications, his beta activity is relatively low, and his stimulator is actually set quite low, in his case 0. Got very dyskinetic if he had this stimulation on during his medication on states. Then as his medicine wears off, the biomarker for motor state, beta activity in the STN in this case, goes up, crosses the thresholds, and triggers this increase in stimulation current to about 1.3 milliamps. And likewise, this occurred reliably over 3 cycles of medications. And this patient felt a lot better on the closed loop stimulation than on the open loop stimulation, where he would have had to constantly change himself stimulation levels to account for those medication changes. So this work uses an interface, the Summit RC+S, which is very flexible, but it's also very complex. We get the flexibility from programming the device's functions ourselves in the application programming interface of the device, which is a new technique for most investigators. So we worked with 3 other academic sites, including Greg Worrell's site at Mayo Clinic, in the so-called Open Mind Consortium, which is a group that is sharing technology related to these new types of neural interfaces. And there will be a workshop on this on June 3rd. You can contact us if you would like to participate in the workshop and haven't already heard about it. This is the large team that contributed to these, and this work was funded mainly by the Brain Initiative UH3 grant. So just to summarize, I've talked about a new investigational implantable device, the RC+S from Medtronic, that allows continuous wireless invasive brain recording at home. I've illustrated it in Parkinson's disease, but this is actually a very flexible platform that can and is being used in a wide range of disorders, including pain, epilepsy, and psychiatric disorders. We've shown that behavioral states of high clinical relevance in Parkinson's, such as the immobile versus mobile and dyskinetic states, can be resolved with brain recordings at both basal ganglia and motor cortex sites. We've also shown that unsupervised machine learning can identify these relevant neural signatures, and that could obviously be applied to other brain conditions as well. And we've illustrated the use of adaptive deep brain stimulation now with a fully embedded device. Thank you. Our next speaker is Nanthiya Suthana, who is assistant professor at UCLA, who will be talking about brain recording in other systems.
All right. Hi, everyone. I'm going to talk today about mobile deep brain recordings and stimulation in another system, the NeuroPace responsive neurostimulator, and how it can help neuroscientific studies of naturalistic behaviors in humans. So as a neuroscientist, the traditional measures of neural activity in humans suffer from the inability of participants to move. So there are movement artifacts that restrict them to stay still. This is, techniques like fMRI and others. And some of them also record and stimulate from superficial areas. And the tasks that are used are also on computer screens, 2-dimensional, and so low in ecological validity. So with the development of the responsive neurostimulator and other chronically implanted systems, we are able to record intracranial EEG, as you can see above here, in an example raw trace from a patient that has a system implanted in the hippocampus. And in these patients, we can record intracranial EEG as well as various other behavioral measures such as motion via full body motion capture system, which I will show you here in this video. So if you could play this video here. And in the video, you can see a patient walking around as their movements are being captured with sub-millimeter precision. They can also wear a scalp EEG cap and other wearable technologies such as virtual reality headsets, augmented reality headsets for simulating more naturalistic experiences with higher ecological validity. So this is the full platform that we've developed, which is a series of accessories that allow us to, in real time, view the intracranial EEG data, as well as insert markers to synchronize it with wearable data streams, and also trigger on demand the stimulator for various experiments. So it involves various accessories that are carried in a backpack that weighs about 9 pounds, but there are also lighter weight versions, depending on the participant, that are a little bit less accurate in terms of synchronization, so about a half a second versus milliseconds. You can also use this platform to do stationary computer-based tasks, traditional neuroscience studies, to compare those as well. The participants can also wear various wearables that can record physiological measurements such as skin conductance rate, respiration, heart rate, pupillometry, eye blink responses, and they can do so either indoors in the laboratory setting or outdoors in natural settings in their home. And this is what it looks like, you know, the full wear up and full setup and the lightweight version as well. And again, the headsets of your choice, so virtual reality and augmented reality headsets of your choice, or just eye tracking headsets that are coming out these days that are quite effective. So what can you do with this platform? You can do various neuroscientific investigations. My own lab studies episodic memory and spatial navigation through a UO1 funded project, but we can also do studies that are relevant for neurologic and psychiatric disorders, whether it's developing new treatments and testing those treatments. So we have a collaboration with Jean-Philippe Langevin, who actually has a poster here at the Brain Initiative on this UH3 project for using the RNS to treat PTSD in combat veterans. And we also have another one, collaboration with Stanford, Casey Halpern, looking at loss of controlled eating. So this platform in my own lab, we are using to understand the electrophysiological features of memory and spatial navigation. So we have another video here. If you could play this one, you can see a participant navigating a virtual reality environment, and they can learn various locations that we can measure their memory for via a handheld joystick that they press a button when they remember where they are. And then we've done this in 5 participants so far. We see a learning rate that is increasing over repetitions of the experiment. And then we can see what's happening in their brain. We find the presence of theta oscillations, these high frequency oscillations that are implicated in memory and navigation, and they seem to be more prevalent when walking faster versus walking slower. And we also see these theta oscillations carry information about where the individuals are in space, as well as the heading direction with respect to the orientation of the room. And this is analogous to this, grid cells that are recorded in these same areas, entorhinal cortex, that are thought to be important for spatial navigation. So we've done this in 4 participants so far, where we see theta activity is higher during orientations that are aligned with the grid that is in the individual participant. And for more information, you can look at the article that's online. We've also found that the theta oscillations carry information about whether you are closer to a wall boundary or farther away from that boundary, in that the power increases closer to boundaries, potentially reflective of boundary-related mechanisms that have been found in single cells and rodents. And gamma activity also seems to differentiate these 2 positions in a space. Interestingly, we found that this boundary modulation, which was present very strongly in all participants tested, is further modulated by their cognitive state. So if a participant is focused on a task that requires a higher memory demand, you see that differentiation between theta in the boundaries versus the inner, but you don't see it when they're just following cues that are located on the wall. Lastly, we've used this platform to look at the neurophysiological mechanisms of hypervigilance and emotional memory to motivate the UH3 for treatment study for PTSD. We record physiological measurements while participants have amygdala and hippocampus and prefrontal and/or recordings to look at activity during the presentation of images that carry valence, either positive or negative valence. So this is the IAPS database for affect. And we see that in participants who have comorbidities, such as PTSD or generalized anxiety from the veterans, we're collaborating with the VA in Los Angeles, we see an increased theta activity about a half a second after the onset of the stimulus. That's around 6 hertz in the right basolateral amygdala. We don't see this in hippocampus or other areas, so it's specific to this area here. And we're exploring whether there's a difference between individuals who have anxiety disorders versus those that do not. And we've tested so far 5 participants, and there's a trend in the fact that this theta activity is increasing in all of them during negatively viewed images that have negative valence compared to positive. So that finding here is going to help motivate the clinical trial to treat PTSD patients based on this biomarker, this theta oscillation in the right amygdala. So to summarize, this platform so far has enabled studies to look at theta oscillations during memory and spatial navigation, specifically walking behavior, and how in humans, for the first time, we see that it carries information about actual position in space, not just virtual space in a computer task, and that this positional modulation, whether it's boundary related or grid related, is stronger after memory is formed or in periods where high memory demand is relevant. And then we see low frequency theta oscillations in the basolateral amygdala in the right hemisphere in a small subset of patients after they view negative stimuli compared to positive stimuli. So we're translating that last finding into this clinical trial. This is just showing one patient's clinical scores for PTSD over almost 4 years with a continuous stimulator, which will now move into a theta-triggered responsive stimulator with the use of the RNS. And there's a poster here at the Brain Initiative if you're interested in finding out more from PI John Sleep Langevin. So altogether, to summarize, this is a novel research platform for cognitive and clinical neuroscience studies. You can, with this platform, enable wireless stimulation and recording that's programmable and in real time in deep brain regions of freely moving behaviors in patients, in participants who have the implanted RNS. And then when combined with wearables like VR and AR headsets, motion capture, physiological measurements, you have an opportunity to investigate naturalistic human behaviors under experimental control and answer neuroscientific questions here, and also develop new therapies and test those therapies in more realistic environments before the patients go out into their homes. Ethical considerations for this system include when you do research studies, potentially withholding the responsive neurostimulation treatment. Of course, this is up to the decision of the participant, and actually can be prevented if you optimize recruitment, which is what we do to include participants that have very low seizure activity so that there aren't that many detections during the research. The research studies utilize a very low amount of battery, but this is an issue, of course, that needs to be taken under consideration. So what we do is limit research time per participant. There are over 2,000 participants in the US right now with the NeuroPace RNS, so there are plenty of participants to sort of recruit for research rather than doing all the studies in one participant and thereby reducing their battery such that they have to be replaced earlier. And then, of course, you want to ensure security of any kind of connection, of wireless connection between any additional accessories that allow the platform to view the data in real time. And so we have various ways of doing this as well. So with that, I'd like to thank the lab members, postdocs, and graduate students, and all of the collaborators and funding that supports this work. Thank you. And I'll introduce the next speaker, which is Michelle Armenta Salas, to speak.
Okay. Hi, everyone. I'll be talking about the year 1 results for the Orion Visual Cortical Prosthesis, the early feasibility study. So this is a clinical trial sponsored by Second Sight in collaboration with UCLA, Baylor College of Medicine, and the Alfred Mann Foundation. Just as a little bit of a background, so I've been one of the researchers that have had the pleasure to work with all of these clinical trial subjects and collaborated with the researchers at UCLA and Baylor to plan and execute a lot of our research sessions, but also be able to program and fit the system so the subjects can take it and use it at home. And this has been partially funded by the Brain Initiative, apart from the Second Sight. So just a brief overview on the Orion system. So this is a visual cortical prosthesis that was designed to directly stimulate the the visual cortex, bypassing the eye and the optic apparatus to elicit some type of artificial vision in completely blind subjects. So it has 2 main categories of components. So the first ones are the implanted components, and this is has a subdural electrode array, which is 60 non-penetrating channels, which are placed interhemispherically on the occipital cortex of the subjects. This connects through a cable to an electronic package and an implant coil, which are fully implanted. So this just lay flush on the skull and communicate wirelessly to the external components, which are the one that the users wear. So these components are a pair of sunglasses that have a video camera that communicates to a video processing unit, which is the one that would actually translate the video images to stimulation parameters that are sent to the implant via an external coil that sends it through an RF link. So this sends both the data and the power. So there are no actual implanted batteries that need to be replaced in the system. So the early feasibility study is an open-label, single-arm 5-year study with 6 subjects at 2 different centers, as I previously mentioned, in UCLA and Baylor College of Medicine. And the primary outcome for this study is the safety evaluation measured through the reported adverse event. Our secondary outcome measure is to test the functionality of the device. So what's our ability to produce phosphines, that is visual percepts in these blind subjects, test the device longevity, and assess the benefits in terms of the functional vision that we're able to deliver, as well as the impact on the quality of life that it may have for the subjects. An overview of the status and the subjects that we have. So we have a total of 6 subjects, which we were able to recruit and implant within the first year of the study. So 4 are at UCLA and 2 at Baylor. The average age at the time of implant was 49 years, and the average duration, so as of earlier this month, was around 24 months. So all of the subjects currently have a functional system, and they've all taken it home and are able to use it according to what the principal investigator indicated for each patient. For our primary outcome, we had a total of 8 adverse events across 3 of our 6 subjects. So we had 1 serious adverse event for 1 subject and 7 non-serious, either device or procedure related, across the 3 subjects. We had no unanticipated adverse event. And just to put this in a little bit of contrast with the previous device, that is a retinal implant from Second Sight. So this is the Argus 2 feasibility study. At 12 months, in the first 5 subjects, they had actually reported a total of 25 adverse events, 2 serious, and it was across 4 of the 5 subjects. So the outlook so far at the 12 months with Orion is looking actually a little bit better than what we had experienced with the Argus 2. And we obviously continue to monitor all the adverse events and process it with the sites. For our secondary outcomes, we test the functional vision in a few different ways. So the first set of tests are trying to be a little bit more objective and controlling what the subjects report and what they're able to see when they're using the device with the camera. And the second kind of batch of tests is trying to get a little bit more on the subjective side. So for the first set of tasks, we have the first one is one called square localization, where the subjects are asked to localize a single white square on a black background on a touchscreen. So we control the input that we're obviously giving it through the camera, because we set them in a very black room, and they just scan around, and they should localize where they see the square and when they find it. And we measure the error looking at the distance between where they point and where the square actually was shown on the touchscreen. And we do all these tests with the system on and the system off. So if any of the subjects may have, even though most of our subjects have no light perception, some may have some bare light perception in the opposite eye. So we allow them to use maybe whatever they had still left. So for all of our subjects, we observe that the majority perform better with the system on than the system off, which is what we would want and we would expect, except for subject 3 that actually perform worse with the system on than the system off. And this was due to the nature of where the percepts are localized in the visual field of the subject. And I can talk a little bit more about it if you have questions. We observed that actually the spread of the response, so like the randomness, is actually less when the system is on than off for the subject, even though the overall average error is larger. The second task tries to look a little bit more into like the next step, so how the subjects are able to use the spatial information of the phosphenes that they see from that we are able to elicit with the device. So the task is called Directional Motion, and here we present a single white bar, again, that sweeps across the black touchscreen, and we ask the subjects to report the direction where they saw the bar moving. So they keep their eyes and their head fixated, so they're not allowed to scan, and the bar can move in any of 360 degrees. So it's a little bit of a hard task, and given the field of view that we have available with the implant, but the subjects perform reasonably well so far with it. So we test again with the system on and the system off, and we observe that all of the subjects have been able to perform significantly better when they're using the system. The third task is gradient visual acuity. So this is a test that allows us to measure ultra low vision acuity. So it gives a report between 2.9 and 1.6 logmar, and it shows a series of gradients in 4 different orientations. So either vertical, horizontal, or either of the diagonal. So here on the right, we see one of just kind of an example with one of the subjects performing the task, and the gradients are shown for only 5 seconds. So they can do very short, small scanning, but it would give us an idea of how well they can process this information and maybe how it can later be used to maybe advance towards form vision. So we test this with the system on and the system off, and 3 out of our 6 subjects have been able to score with the system on, and none of them had been able to score with the system off. The next set of tasks, it actually looks a little bit more, it tries to probe a little bit more the subjectiveness of the vision. So how well can they actually use it in the real world, and how much is it useful for them? If it's something that would require like a lot of training, or even when they have the training, if they're able to use it in their activities of daily life. So for this one, we have the FLORA, which kind of take advantage of using trained observer to assess whether the system or not is actually having a positive or negative or just a neutral impact on the subject's life. So they perform a battery of different activities of daily living, and as I mentioned, a trained observer evaluates how well or how can they perform these different tasks. So it gives a final rating on the benefit that the system has on the subject. And we see, and we get the report at the 12 months that the majority of the subjects, so 5 out of 6, had either a positive or a mild positive impact by using the system. Again, just as a brief comparison of summary, we've seen that the system has been able to have an improvement in the functional vision and their ability to perform everyday tasks when the subjects are used in the system. And in comparison to what we had observed with Argus 2 at the 12 months, we see that we have either very comparable or even better for some of the tasks, for example, in directional motion, and slightly better with the Flora report than what we had observed with Argus 2, even though we have a very limited amount of subjects right now with this study, since it is an early feasibility study. Lastly, what we also like to collect is to look at how the real world use. So what happens when the subject just have the device at home when they're working with rehab specialists that go to their house and train them to be able to use the device, and what expectations they have to keep on using the device in the future. So we sent a questionnaire just asking about their expectations and their experience so far with the device, and hear back from the rehab personnel of what they've been able to do and what they've been able to work with the subjects, and kind of like the different tasks that they've been able to perform. And we hear back and we've observed that the subjects are able to use the Orion system in everyday activities, even for very simple things that we would consider simple, but for them it's a huge achievement. And right now they expect to keep improving, not only to improve the vision that we're able to offer with the system, but also to keep on improving on the tasks that they are able to do. And just in the following video, we're going to show an example of one of the subjects, and this was given by the research team at Houston. So here we see the subject able to use the system, navigating the hallway corridor of the hospital, being able to find corridors, to find windows in the corridors using different like the light and dark cues, and being able to navigate by himself without the assistance of a cane. Okay. Okay, and thanks a lot for your attention. I'm be happy to take any questions. And up next, we're going to have Dr. Harrison Walker. He's an associate professor of neurology and the medical director for brain stimulation at the University of Alabama in Birmingham.
My talk is entitled Changes in Therapeutic Window as a Result of Directional Brain Stimulation. We're grateful to our sources of funding, including a UH3 grant from the NIH Brain Initiative. Directional brain stimulation is among a few new device technologies that are available in neuromodulation. And I think that directional leads are a unique window into the pathophysiology in human brain circuits. Directional and closed-loop stimulation both show promise, but they're actually largely unproven and greatly increase the complexity of DBS therapy because of their great flexibility. The picture on the right shows a directional brain stimulation lead, and the red blob around the lead is a computational model showing steering of current away from us into the screen by the directional orientation of the contacts on the lead. So this lead is made by Boston Scientific, who's our industry collaborator, and it's in the so-called 1-3-3-1 design. So there are traditional circular leads at the extremes, and the two middle rows of contacts are virtual rings with directional DBS contacts. This is particularly important in the subthalamic nucleus, and some of the local anatomy is highlighted below the picture. The STN is located very near eloquent structures that can cause benefits and side effects as well. And so we'll discuss in this talk our characterization of how directional DBS affects side effect thresholds, therapeutic window, and motor efficacy. And also I'll touch on new candidate biomarkers that we might use to simplify and guide us in postoperative programming with both directional and potentially closed-loop systems. Finally, I'll discuss some ethical considerations that relate to crossover studies in neuromodulation. So this is the current status of our study. We're in year 3, and this is a small randomized double-blind crossover design. And we have screened 31 and implanted 24 participants. And the crossover occurs longitudinally at over 2-month intervals. Circular DBS, as we define it, is using the 3 contact segments in the virtual ring together, as depicted on the left, whereas directional brain stimulation is essentially anything else. In this example, contacts 2 and 4 are active. And these settings are arrived at based on traditional behavioral brain stimulation programming. The data in this talk arise from the orange boxes in our study flowchart. So we'll have some behavioral data from our pre-op baseline assessments. We'll briefly touch on some local field potential data that we've acquired during DBS surgery. And the behavioral data is all from what's called the monopolar survey, or the initial session where we activate the device and query each contact on the directional electrode for its potential benefits or side effects. And we've learned that directional brain stimulation in the STN has a strong effect both on side effect threshold and on therapeutic window. The side effect threshold is the stimulus amplitude at a given DBS contact that elicits unwanted side effects. In the subthalamic nucleus, this most commonly is contralateral contraction caused by activation of the nearby internal capsule, the lateral corticospinal tract. And if you look at a directional lead at the side effect threshold for each of the contact segments and rank them from best to worst, as depicted here on the left in these 2 panels, the red dotted line is the side effect threshold using the virtual ring, and the first, second, and third rank contacts have better, intermediate, and worse side effect thresholds. So directional stimulation, on average, improves the side effect threshold in one contact among the directional contacts by about 0.5 milliamps. And actually, in many cases, the worst contacts worsens the side effect threshold also by about 0.5 milliamp. Therapeutic window is a similar idea to the side effect threshold. This is the available range of stimulation intensities that provide meaningful clinical benefit. And we see a similar gradient with about 0.5 milliamp improvement in therapeutic window and some worsening in therapeutic window with stimulation through a contact segment that's the least optimal at a given row on the DBS electrode. This relationship holds both for the dorsal directional row and for the ventral directional row. The data are split here to illustrate this. We're also querying the behavioral effects of directional versus conventional circular stimulation. So in these panels, we're looking at some validated motor tasks. On the left 2 panels, they're measures of gait. They include the comfortable walking speed and the timed up and go test. And in the bottom right panel is a 9-hole pegboard upper extremity dexterity task. The gray boxes are both the pre-op baseline state off medications and the DBS off state after implant off medications on the day of the monopolar survey. And then we've illustrated change in these motor behaviors with the best rings setting and with the best directional contact settings within each individual. So each participant represents a single colored line segment on each of the graphs. And not surprisingly, DBS is, and this is unilateral DBS, is markedly beneficial for these measures of gait and for upper extremity function. However, I would also highlight in the bottom right that the best directional contact versus the best ring, the downward slope of most of the lines in those line segments does strongly suggest greater improvement with directional stimulation versus the best ring. And this was, even though this is an interim analysis, this has reached statistical significance, at least with our currently enrolled sample. Somewhat similarly, there are trends towards greater improvement with directional stimulation in the two gait measures, although we're still enrolling subjects. And these measures are double blind, so the participant and the examiner both are not aware of the patient's stimulation status in this behavioral testing. One of the issues in general with brain stimulation and postoperative programming is that activating the device is very time-consuming and tedious, and it can be a trial and error process. The particular patients in this study spend half the day activating the device, which is quite a bit longer than most activation sessions in routine practice. And one of our goals in the long term from this project is to develop and understand biomarkers that can give us guidance as to how to activate these more complex devices. This is one example of such a biomarker that we've more recently developed interest in. This is both stimulation and recording from a DBS lead implanted in the subthalamic nucleus. So we stimulate in a bipolar fashion from two contacts on the lead and then record from the unused contacts on the DBS lead. And I won't go into all the technical details, but we're now able to remove the very, very large stimulus artifact that is related to stimulation in such close proximity to the stimulation site. And here we're delivering pairs of stimulus pulses. So the test stimulus of interest is delivered at time 0. And prior to the test stimulus is another stimulus, which we've actually subtracted out or removed, we call a conditioning stimulus. And the conditioning stimulus marches in time towards the test stimulus. And when it begins to encroach upon the relative refractory and the absolute refractory period of the elements that are being activated by the test stimulus, you can see in the inset that this local response is abolished. It's diminished in the relative refractory period and then abolished. And I would say that the first response, which is extremely fast, so this is 350 microseconds after stimulus onset, this is probably the earliest recordable interaction between the DBS pulse and human brain tissue that can be measured from an extracellular recording. So both that very early response and then a later oscillatory response, which I'll discuss in a little more detail later, they're both abolished during the absolute refractory period. We're looking at this now in the directional brain stimulation context. So here we have a directional brain stimulation lead with a 1-3-3-1 configuration, and we're delivering stimulation from the circular leads around the directional contacts. So the recording is occurring in the middle rows, the dorsal and ventral row, stimulation at the extreme ends from the circular electrodes. And the array of panels is in the same spatial orientation as in the schema. So each panel is from one directional lead. And in the bottom panels, we see the spontaneous resting local field potential with a peak in what these are continuous wavelet transforms in the beta frequency band, in this case at around 20 hertz. And interestingly, the directional lead detects these potentials, these microscopic subcortical potentials in a spatial gradient. So in the bottom left and the bottom right contacts, there is a stronger, greater power in the beta frequency band and in other spectra as well. And in the middle bottom contact, there is a decrease recording of the beta frequency. Interestingly, above, we're looking at the stimulus evoked activity from the last slide as a function of interstimulus interval. So you can see that actually in all of these directional contexts, there's both an absolute and a relative refractory period. So this is a validation that these are biological signals. And there is, in this individual, a very robust correlation between the amplitude of this later oscillatory activity, which has been called ERNA, or evoked resonant neural activity, and the beta band. So where ERNA is brighter, the beta band is brighter. Where ERNA is less intense, the beta band signal is less powerful as well. So this is merely an example of the some of the physiology that we're interested in. We would like to make DBS systems more accessible, more robust, and we would like tools to tell us how to use these technologies, which are increasingly challenging the kinds of clinical programming strategies that we have employed with some success in the past. There are ethical considerations with a crossover trial in neuromodulation. One of the obvious considerations is that an individual participant might be randomized to a therapy that's ineffective. I think that there's particularly a potential for greater risk for something like this if there is a biomarker-based programming strategy that isn't based on robust physiology or imaging, or if it's not linked to behavioral observation. So there are a couple of mitigation strategies for this. One would be to allow flexibility within the constraints of the randomization scheme. So, for instance, in our protocol, we have circular versus directional DBS, but there is quite a bit of flexibility within those two broadly defined categories, and patients can return for stimulator adjustments if needed. Another option is that we've taken advantage of is to use an active comparator and not a negative control. We know in the case of brain stimulation for Parkinson's disease that a negative control would not be tolerated well by participants. And so this decreases discomfort and increases ability to participate in the study. Other strategies might be limiting the duration of exposure to the different conditions in randomization, and perhaps even an early exit strategy to terminate a randomization arm if it's truly intolerable. Finally, one sequela of the COVID-19 pandemic is that we currently have participants who are stuck in randomization arms, and we're awaiting the in-person assessments that are necessary to gather the outcomes in our study. So in conclusion, in these interim analyses, we see that directional DBS improves both the side effect thresholds and therapeutic window versus conventional circular brain stimulation within participants. And this is with, at least in our acute testing during device activation, this is with comparable or probably better motor outcomes during acute stimulation, although we're still enrolling participants. There are a variety of candidate biomarkers, whether stimulus evoked field potentials or resting and task-based local field potentials. I think that they all show promise to guide not only directional but also adaptive DBS strategies. But I think robust biomarker validation is required with suitable sample size and other measures to ensure their validity. Finally, we remain blinded to our primary motor and non-motor outcomes and will not be unblinded to those until later in the study. Thank you very much for your attention. I'd be delighted to answer any questions. And I'm pleased to introduce the next speaker, who is Dr. Winston Chiong, who is Associate Professor of Neurology at University of California, San Francisco.
I've been asked to present on neuroethics, and in particular on points to consider for those envisioning novel human applications of neurotechnology research. I'd like to begin with two broad questions that structure the rest of my remarks. First, BRAIN and other funding agencies have emphasized what's been called neuroethics integration, and my presence on this panel is one reflection of that commitment. What does such integration really mean, though, for the practice of neuroscience? I think in some ways it's a real departure to expand conversations in neuroscience to bring in philosophers or social scientists or legal scholars. As someone who's also a clinician, I think we can look to the precedent set by the integration of bioethics in medicine, where bioethics is now a routine part of clinical curricula and clinical practice. But we know from this history that interdisciplinary exchange is not always easy or straightforward. We think that one meeting point for this exchange is empirical research in ethics, which might be a new concept or an unfamiliar concept to some in attendance. We don't want neuroethics to be purely speculative and engaged in science fiction. We need deliberation and policy that are rooted in evidence about stakeholders' experience and about how neurotechnologies are actually used. Otherwise, as we've already seen in some domains of neuroethics, there is a danger of falling into what has been called neurohype. In these remarks, I'm going to take a brief tour through some topics that affect many research projects in human neurotechnology and highlight some of the empirical work that we've been doing and that other groups have done to inform deliberation about these matters. I also encourage you to visit poster NE2, where my co-PI Dan Dohan will present some of our group's work in more detail from the last year. This symposium is focused on novel human applications of neurotechnology. One central ethical tension in many such applications is that, in general, potential surgical and anesthetic complications would make it too risky to implant electrodes or a device for testing in healthy people. However, in neurosurgical patients who already have clinical indications for an intracranial or an intraspinal procedure, the marginal added risk of testing a new technology or conducting an experiment can be reduced, such that risk-benefit ratios that would have been unfavorable may instead be reasonable. But we should also be aware then that such studies preferentially require the recruitment of potentially vulnerable patients with conditions such as chronic pain, brittle Parkinson's disease, or drug-resistant epilepsy requiring neurosurgical intervention. This situation has many parallels with the ethics of clinical trials, in that present patients serve as research participants in studies that could provide benefits to other people in the future. In our work, we've drawn upon the broad existing literature on ethical issues in clinical trials. In our empirical work, we've conducted interviews with investigators from 19 NIH-funded intracranial electrophysiology studies and have identified two broad types. What we call opportunistic studies, in which there isn't a direct benefit to the patient in participating, often used to explore fundamental questions in human neuroscience, and what we call experimental trials for novel interventions, in which there's a potential benefit, but in many cases, greater marginal risk. A key issue in all human research is informed consent, which is often made more challenging by the complexity and unfamiliarity for many patient participants of novel neurophysiological techniques. How can we enhance comprehension and ensure that research participation is truly voluntary? In our empirical research, we found a lot of heterogeneity in current approaches to consent, and one particularly challenging topic is whether a clinician investigator, such as a neurosurgeon who has clinical responsibility for the care of a patient but is also a PI of a lab, should be the person to obtain consent, or whether this is a role that should be played by a research coordinator or a research fellow. On one hand, clinician investigators are often the people on the team who are best positioned to advise about the clinical implications of research participation for an individual patient. But there's also a worry that patients might not feel able to say no to a doctor who's also treating them. We think it's often appropriate for clinician investigators to obtain consent, and regardless of which member of the team attains consent, there have to be other safeguards to ensure the voluntariness of research participation. We've also been researching innovative models and frameworks for consent to inform best practices for human neurophysiology studies. Another key topic is the issue of post-trial obligations to participants. This has been less a focus of our own work, but one that Brain has supported extensively. And I'd refer people to work by Gabe Lazaro-Munoz and Saskia Hendricks. To some extent, I think this issue implicates broad structural issues in research rather than issues of individual investigator morality. As a community, we need to devise new mechanisms for supporting research-related medical needs that participants might have, such as technical support for patients who wish to continue using a device, explantation for patients who'd rather not have a device, and equipment issues such as battery replacement. Prospective participants should be aware of these potential future needs and plans to address them as part of the consent process. Our lab has a particular interest in new closed-loop brain stimulation devices that both record and decode neural activity and deliver appropriate stimulation based on those parameters, as described by Phil and Nanthia. Because these devices rely on semi-autonomous algorithms that may operate outside the patient's awareness or without the direct involvement in real time of a neurologist or a clinician, some ethicists have envisioned potential threats to patients' identity or autonomy from their use. In our work, we focused on the NeuroPace RNS device, which is the device that was described by Nanthia. And this is the only responsive brain stimulation device in regular clinical use. In some ways, we think of patients with these devices as pioneers in neurotechnology. We have more information at our poster, but we've been meeting patients preoperatively and following them for a year post-op to get a better sense of their concerns and how they're using the device and how they're integrating the device into their daily lives. So far, issues of identity and autonomy haven't been major concerns for these patients, although they're still relatively early in their clinical course. There is an unexpected finding from our work that we're interested to share with the broader community and get feedback about. In general, ethicists thinking about closed-loop neuromodulation have focused mainly on the stimulation or neuromodulation limb of the loop. In our work, though, we found that the ability to record, store, and display electrophysiological markers of illness itself has a transformative influence on many patients' self-understanding, in some ways independent of the actual treatment that's delivered. I think that this is something worth considering for all devices that have recording or sensing capabilities, and we have more to say about this in our poster. RNS is also interesting to us as a study in the dissemination of a new neurotechnology. It's one thing to develop an effective treatment, and another thing to actually get people to use it, get them out into clinical or commercial practice. We've also been conducting in-depth interviews with clinicians and neurotechnology investigators. If any of you, our interviewees, are in the audience, thank you so much for your participation. One theme has been the broad collaborations necessary to conduct and support such work. Really, a single person or even a single discipline's expertise is never really enough to get these projects going. Related to our findings about neural recordings, stakeholders expressed some concerns about how data are used and questions about privacy and ownership of these data. Also connected to what I've said before about neurohype, we've heard about a need to balance long-range fears against a detailed understanding of current limitations of these devices. Zooming out, it's important to think more about the ethical culture of neurotechnology as a field. Again, one feature that's very interesting about neurotechnology is that it requires input from many different disciplines, where each have their own ethical traditions. In our interviews, we found that clinicians' approach to ethical issues in their work is structured by their prior exposure to bioethics. Meanwhile, we found a lot more variation in investigators' engagement with neuroethical issues. To some extent, there's an element of the division of cognitive labor. Not everyone in neuroscience needs to be a neuroethicist. But we have noticed that investigators who come from training programs or are currently in research groups where there's more integration of neuroethics often do have greater comfort and facility in addressing such issues. An important question going forward is whether there's more that we should be doing institutionally to foster such models for neuroethics training and practice in neurotechnology. This is a good place for me to transition to sharing details of our community at UCSF, including many of the people who've done the work that I've talked about today. Also, before we shut down in-person activities due to the current pandemic, we've had a very active year full of neuroethics meetings and discussion, which we found very valuable. And we've been very grateful for the support of an NIH Brain Neuroethics grant, as well as our many neurotechnology collaborators that have really enriched our work. At this point, we'd be very happy as a group to open things up to live questions. At this point, we'd be very happy as a group to open things up to live questions.
But I'd like to thank the time to, and I'll first turn it over to co-organizer, Starr, and a few questions that were directed to him.
Greg, there was a lot of feedback on that. I wonder if people could mute when they're not talking, and I wonder if you could repeat that question. There was a lot of feedback on that. I wonder if people could mute when they're not talking, and I wonder if you could repeat.
Yes, Phil, under the tab, there are a few questions that were in your box. If you would like to select from that list, we probably have time for one question for each speaker.
Sure, thanks, Greg. So one question that I had is for the RC+S device. One of the Neurotechnologies illustrated here for brain sensing is how well does it work in the setting of stimulation artifact from therapeutic stimulation? And this is a big problem with these, many of the implantable sense and stim neural interfaces. The RC+S does have some nice features to deal with sensing during stimulation, including stimulation blanking for brief periods, as well, or sensing blanking during stimulation, as well as active recharge for the second phase of a biphasic repolarization. That being said, there's still a lot of restrictions. You can sense on the same array as you stimulate, but there are only certain configurations where that really is practical, even with RC+S.
Great, thank you. Nanthia, if I think there are a couple of questions. If you can see the tab pull down.
Unfortunately, I don't see the questions for some reason. I'm not sure why.
Here, let me read it. What are the primary differences in brain signals, for example, hippocampal theta, in a virtual laptop task versus real navigation that you've been able to explore for really the first time?
Right, that's a great question. To really answer that, we would need to run the same task during a laptop scenario as well as ambulatory. And while we've done that, we haven't quite finished analyzing the data to be able to say. But my intuition is that the signals perhaps would be stronger. There may be, obviously, if there are movement-related signals, then those would be more dominating during the ambulatory setting. That's actually a question that we're very interested in. How does movement, acceleration, speed, vestibular, motor, visual input, how do all those variables interact during a natural, walking situation? And we're exploring that now. So don't really have a good answer for that. But my intuition is that the signals perhaps may be stronger and maybe more dominated by movement in certain cases and not others, although, yeah, to be determined.
Nanthia, while you're on, I wonder if I could ask you another question. A big question in epilepsy, of course, is what residual functions, say, does a damaged hippocampus have, that we need to think about if we're going to resect it or not? Have you had a chance in your work to look at, say, navigation functions from, MR intact hippocampi versus maybe ones with a little bit of hippocampal atrophy? And what are your thoughts about that residual function of possibly diseased hippocampi from your work?
Right. Yeah, that's a great question. To this day, we've been focusing mostly on the normal, hippocampal region. And if we do have a patient that has atrophy, we exclude those channels for the scientific questions where we want to generalize to normal, human hippocampal function. However, as we start to, expand these studies and look at, be able to look at participants who have atrophy or other structural abnormalities, hopefully we can answer that question. But we haven't done so yet. Yeah.
Thank you, Nanthia. Harrison, can you see the question directed to you?
Yes, I can see it. Can you hear me?
Yes.
So the question is the advantage of directional stimulation only for reducing stimulation side effects? And I would say that the answer to this is not clear. It's a very important question. So the directional stimulation clearly modifies stimulation side effect thresholds and therapeutic window. In our acute data from device activation, there is evidence that it improved the dexterity of during a 9-hole pegboard dexterity task. So it improved the time to complete the task. And in our interim analysis, it did so in a statistically significant manner versus the corresponding virtual ring. The size of the effect is relatively small, but this was a double-blind assessment. So both the participant and the person who measured their symptoms were not aware of whether the condition was directional versus circular stimulation, and directional versus circular stimulation was delivered in random order as well. So I think that this is kind of an acute assessment when we're kind of going through a whole bunch of stimulation parameters at once, but I think that it does provide some suggestive evidence that there could be greater efficacy in some individuals in some settings with directional versus circular stimulation. I guess that the real, a more definitive answer to this will be in our longitudinal assessments when patients have been allocated to either directional or circular DBS for 2-month intervals. And then we'll really hopefully be able to kind of tease this out more in whether it's a sustained difference versus relatively acute improvements that we're seeing in upper extremity function versus the circular DBS. The other thing I would mention is that there are some encouraging trends in the gait speed and in the timed up and go task as well. So I guess the book is still open, but I think there are some interesting potential signals of efficacy beyond the side effect question. And these side effects are very, very important. I mean, it's important in a patient with movement disorders there are just times when you want to turn the stimulation intensity up. And so the ability to, in a practical sense, to be able to avoid that, it seems at some point that could be useful. The flexibility.
Great, thank you.
Thank you.
And Winston, there's a question for you.
All right, I'll take that one. I've been asked to comment on the ethics of psychiatric research and responsibility to maintain, I guess, that at a level of other brain research. So I think maybe reflecting, among other things, that in this session, there's been a lot of discussion about applications in neurological disorders and less in psychiatric disorders, although Nanthia did mention some work in mental health that I'm looking forward to reviewing that poster. I think that one difference right now, and I think there is a lot of active research, but one of the challenges has been understanding the relevant electrophysiology in the case of many psychiatric disorders, and that remains an open and active research question. We do have research programs looking at ethical issues in closed-loop devices for psychiatry. Unfortunately, that's been probably the aim of our neuroethics grant. Has been most affected, unfortunately, by the COVID pandemic and our data collection has been slowed. So reflecting some of the cautions I said in my presentation about the need for evidence and empirical work, I guess we can really just try to extrapolate from our work in neurological disorders and what we envision for psychiatric ethics as well. So I think that one thing that will be common and maybe even more salient in psychiatric research is just the challenges related to informed consent and voluntariness, especially considering the complexity and unfamiliarity of new interventions, as well as particular sensitivities about the relationship between the patient and the clinician. I think extrapolating from some of our work in neurological disorders, we think that biomarker discovery and the ability to display and share electrophysiology with patients may have unexpected effects on patient self-understanding, and to the extent that psychiatric disorders implicate aspects of patients' sense of identity or sense of self, that may be a larger issue to consider. There's been a very interesting theoretical strain of neuroethics that's been focused on questions of authenticity, which is that when we're addressing psychiatric disorders, we may have interventions that affect participants' motivations, including their motivation to participate in the study or their motivation to be well, and that this may raise some novel questions in the area of psychiatry. But here again, I'd caution that right now we don't have a lot of evidence to support this question, but it's one that there's a lot of conceptual motivation for, and certainly something that we and other research groups are really interested in.
Winston, could I ask you a brief follow-up? You've said some intriguing things about the transformative nature of the sensing piece of these neural interfaces. Could you say a little more about that? Do you feel that we have an obligation in these studies to give patients more ability to visualize their brain data, or share with them all of our interpretations of it, so that they can learn about themselves as we are learning about them?
Yeah, no, I think that that's a challenge. So I would direct everyone to our posters. So we do share some of the information we have. A lot of this comes from our interviews and observations of patients who have the NeuroPace RNS device for epilepsy. That's a case where patients describe a lot of interesting reactions to sort of being able to view the data. And sometimes there's an important discrepancy between patients' own experience of illness, their experience of events that they may assume are epileptic in nature when some may not be, and when there's what's been described as an electroclinical dissociation between the patient's experience and what their electrophysiology may be. So I wouldn't say necessarily that, particularly in the case of researchers where the neural signals are different or not fully characterized, I don't think that there's necessarily an obligation to share information that we ourselves may not understand with participants. I can see situations where that might be harmful. I would say more that our research points to the importance of attending more to the sensing limb. I think we think a lot about the stimulation limb, and at least as neuroethicists, we tend to think of the sensing limb just in terms of how effective that makes stimulation. And I think a really interesting thing in our research has just been that the ability to view their illness experience in this different way, in this electrophysiologically informed way, does have some really interesting effects on the way that patients think about their illness experience, and also the way that other people, sometimes in the patient's family or immediate circle, may regard the reality of their symptoms or experiences, or kind of how that changes their relationship with the clinician as well. So I would say more that it's something to pay attention to, and I would imagine that in different applications, this may have different obligations for researchers and clinicians.
Great, thank you, Winston. And Michelle, there were a number of questions directed to your talk, and if you can see them, read the question, and be interested in hearing your thoughts on them.
Yeah, sure. I think I can group at least two of them together. So one, it's asking about the serious adverse event that was reported and how was it treated. And there's another one that asks about kind of that therapeutic margin of that percept versus the after dischargers and the seizure. So yeah, the adverse events was the seizure, and it's only been in one subject. So that happened at the beginning of kind of the programming with that subject. We were testing different frequencies in what the system calls the video mode. So it gets a live video feed and it's doing the sequential stimulation. So as we were increasing the frequency, and he was testing, like covering completely the camera, and then it started having some after discharges, and it eventually evolved to a seizure. It was a partial seizure, and even though it's sort of the system was shut off and he was treated, so that was when he still had EEG monitoring, because it was at the beginning of the trial when they're going sort of that monitoring. This is the first time we're activating the video and everything, and it was mostly resolved by itself within the first couple of minutes. But the clinician, the neurologist that was inside, it still gave them Ativan intravenous, so they have the IV in line just in case of that emergency. And that was the only serious adverse event that we had. In relation to kind of the margin of what the percepts and how I guess the functionality, I guess the question is asking about how the therapeutic margin, and with this after discharges and the seizures. So at least the ability of the subjects overall, the sick participants, to use it and to be able to interpret those percepts in video mode, it so far hasn't, like, we just had that single adverse event, and the other ones, the other events, the other adverse event reported, I think there's been only a couple that were maybe it might have been with after dischargers that happened once they had it at home. So it hasn't truly affected the usage that the subjects are able to have, either in video mode or in the research sessions. So it seems it's right now it kind of outweighs, like their ability to use those percepts. It's much more beneficial so far.
And if there are no comments additional comments from the panel, we'll move to Claudia. Has a couple of questions about the overground ambulation and electrical stimulation spinal cord.
Yes, so the question is simulation location and parameters or patterns for walking and standing. So really it's dependent on the physiology of each individual. We map intensively, so we go through the different electrodes in the array. So we're using a 16 electrode array. All individuals receive the implant on the lumbosacral spinal cord. So the location is very similar in all individuals. But we do map to understand which muscles are turned on at the different sites of the electrode, and then what are the differences in frequencies as well. And that's very, very individual or participant dependent. So in most cases, standing is usually located a little bit more caudal on the electrode, while walking might be a wider spread of the electrode or even a little bit more rostral. But as we train individuals and they get more used to the stimulation, those two things merged a little bit. The frequency usually starts a little bit lower for standing, and the frequency for walking is usually pretty stable between 30 and 45 hertz. But as the individuals train, then they're able to stand for a shorter amount of time at higher frequencies. And that's where we try to adjust and have them learn by using the same electrode configuration and just having to make minor adjustments, either in amplitude or frequency itself. But usually individuals are fairly different, so the physiology is different, the injury is different, so it has to be mapped initially to understand kind of the starting point for each individual.
Thank you. Thank you. And with that, we're about 15 minutes over, but we appreciate again the excellent talks, and I assume that the talks will be available online as well for people if you've missed a portion of a talk. With that, I'll ask if any of the panel have final comments with, in particular, Dr. Starr, since he really did I'll say most of the organizing, and really hats off to the whole panel.
Yeah, thanks very much to the panel. Some folks from NIH also helped organize this symposium to make sure that it was coordinated with other symposia and their speakers and themes at this. So we really appreciate all the speakers participating and doing all the work of pre-recording in advance, which was a bit of an adventure, but I think it worked out. So thank you all very much.